Welcome back. Let's continue our discussions about neurotic disorders. Somatic symptom and related disorders involve physical symptoms that cannot be fully explained by a medical condition and the patient's preoccupation with these symptoms. Essentially, the person is experiencing real pain or other complaints, but the cause is psychological in origin, often unconscious. In somatic symptom disorder, a patient might have one or more chronic symptoms, like pain, fatigue, or gastrointestinal issues, that cause significant distress, yet extensive medical evaluation finds no adequate organic cause. Importantly, the patient's suffering is real. They aren't faking it. The pain or symptom is thought to result from the mind and body's complex interaction, where psychological stress is expressed physically. This is sometimes called somatization, emotional distress manifesting as bodily symptoms. Here are some examples. Somatic symptom disorder, a person who has for months on end various complaints, stomach pains, then headaches, then chest pains, repeatedly visiting doctors. All tests, endoscopy, CT scans, labs, cardiac workups, come back normal, but the person is still convinced something is wrong. They may have health anxiety and constantly seek reassurance or more tests. Illness anxiety disorder, formerly hypochondriasis. Here, the person may have minimal or no physical symptoms, but is obsessed with the idea of being seriously ill. For instance, normal body sensations like mild indigestion or a lymph node become interpreted as signs of cancer or another dire illness. They often doctor shop even after being told they're healthy. Conversion disorder, functional neurologic disorder. This is when psychological stress literally converts into a neurological symptom. A classic scenario is someone who witnesses a traumatic event and afterward becomes blind or paralyzed with no medical cause. Despite normal scans and reflexes, the patient truly cannot see or move their limb. The symptom is not consciously faked, it's an unconscious response to stress. Pseudoseizures are often due to conversion disorder. Despite providers thinking that someone having a pseudoseizure is faking it, they are not. It is just as involuntary as an epileptic seizure, just due to a different cause. Clinical features. Patients with somatic disorders often have a long, complex medical history, multiple doctor visits, negative tests, and frustration for both patient and providers. They tend to be very anxious about their health. The defining feature is a disproportionate concern about the symptoms and persistent anxiety about health. They often cannot be reassured easily. But what if the doctors missed something? I know my body, I feel something is wrong. Course. These disorders can be chronic and debilitating. For the patient, not having an answer for their symptoms is deeply distressing. They may become frequent 911 callers or ER visitors. Each new symptom or a recurring symptom flare up triggers the fear anew. Unfortunately, repeated testing can reinforce the cycle, brief reassurance from a normal test, but soon doubt returns or new symptoms appear. It's noted in studies that a subset of frequent EMS users fall into this category: chronic pain or somatic complaints with repeated negative workups. EMS considerations. Interactions with somatic symptom patients can be challenging. As an EMS professional, you might be dispatched multiple times to the same individual who always has some crisis, chest pain, neurological symptoms, etc. It's easy for providers to become frustrated or label the patient as a frequent flyer. Avoid derogatory or dismissive attitudes. These patients are suffering psychologically, and dismissing them can damage trust and potentially cause you to miss a real medical issue. They can have real emergencies too. Above all, maintain empathy. These disorders blur the line between physical and mental health. As a provider, you must address both, ensure scene safety as well. While these patients are usually not violent, frustration or desperation can cause conflict. Keeping a calm, respectful demeanor will prevent escalation. What causes neurotic disorders? There is no single answer. These conditions arise from a complex interplay of biological, psychological, and social factors. Here are some key contributors. Genetics. Many anxiety disorders, including panic disorder, phobias, OCD, tend to run in families, suggesting a genetic predisposition. For example, OCD has about a 25% chance of occurring in another immediate family member if one person has it. However, genetics alone don't determine destiny, they simply increase vulnerability. Brain chemistry and neurobiology. Imbalances in neurotransmitters and dysregulation of certain brain circuits are linked to these disorders. For instance, low levels of serotonin or GABA, gamma aminobutyric acid, are associated with high anxiety. OCD in particular is thought to involve a circuit in the brain that doesn't properly filter intrusive thoughts, and evidence shows serotonin dysregulation is involved. Many anti-anxiety medications and antidepressants work by modifying these neurotransmitters, which often alleviates symptoms, supporting the biological component. The stress response, fight or flight. Neurotic disorders often represent a hyperactive stress response. When we perceive danger, the adrenal glands release adrenaline, causing heart rate to spike, breathing to quicken, muscles to tense, etc. In anxiety disorders, this fight or flight response can be triggered inappropriately. For example, during a panic attack, the body reacts as if life threatening danger is present when it isn't. Over time, chronic stress hormones, like cortisol, can even affect the brain and body, making one more prone to anxiety. The physical symptoms we see, palpitations, sweating, tremors, etc., are direct results of this adrenaline surge. Psychological factors. Personality and coping style play a role. Some individuals have higher baseline anxiety or tend to catastrophize, always imagining the worst outcome. Past experiences shape these disorders too, e.g., someone who grew up with unpredictable trauma may develop chronic anxiety, their nervous system on alert all the time. Trauma and life experiences. A history of stressful or traumatic events is a major risk factor. Examples: abuse, the sudden loss of a loved one, war or violence, serious accidents. These can all precipitate anxiety disorders. Post traumatic stress disorder, PTSD, is a separate diagnosis resulting from trauma, but trauma can also lead to generalized anxiety disorder, panic, phobias, like a dog attack leading to dog phobia, or somatic symptoms. Even prolonged high stress, job loss, ongoing family conflict can contribute. Learned behaviors. Some phobias are learned. A child sees a parent scream at a spider and internalizes that fear. Likewise, behaviors in OCD can be reinforced. The temporary relief from a compulsion teaches the person that ritual works, so they repeat it, reinforcing the cycle. Cultural and social factors. Stigma and lack of social support can worsen these conditions. On the flip side, strong support networks can help people cope better. In summary, neurotic disorders are typically multifactorial. An individual might inherit a tendency toward anxiety, then experience a traumatic event that triggers the disorder, and then further maintain it via cognitive patterns like excessive worry or avoidance. The exact neurobiology is still being studied, but it's clear that both mind and body are involved. This is important for EMS to recognize. These are real conditions rooted in brain function and life experience. The patients aren't simply choosing to be anxious or fearful. One of the biggest challenges for EMS in behavioral emergencies is distinguishing a primary psychiatric issue from a medical condition. Neurotic disorders often produce symptoms that mimic serious medical problems, and the two may also coexist. Always remember, assume medical until proven otherwise. Here are some guidelines for field assessment. Scene size up and initial impression. Approach every behavioral call with an open mind. Quickly observe the patient's overall presentation. Are they alert and interacting? Are symptoms such as shaking or hyperventilation apparent? Scan the environment for clues, empty pill bottles, signs of drug use, an emotionally charged scene like a breakup or death notification. These context clues can point toward psychiatric causes, but never rule out medical yet. Primary survey, vital signs, and ABCs. Perform a thorough primary assessment just as with any patient. Check airway, breathing, and circulation. Anxiety alone can increase respiratory and pulse rate, but ensure the airway is clear and breathing is effective. Obtain vital signs, heart rate, blood pressure, respiratory rate, oxygen saturation, blood glucose if possible. This is critical. For example, a tachycardic, sweaty, anxious patient could be having a panic attack, or they could be hypoglycemic or in shock. A low blood sugar can cause bizarre behavior and anxiety. Hypoxia can cause agitation. Don't attribute abnormal vitals to anxiety without ruling out causes. Rule out common serious causes. Many serious illnesses can present with anxiety or mimic it. Cardiac. Chest pain and anxiety might be an acute coronary syndrome, heart attack, or arrhythmia. Always consider doing an ECG for chest pain. Never assume chest pain is just anxiety in the field, regardless of the age of the patient. Respiratory. Difficulty breathing and hyperventilation could be an asthma attack, pulmonary embolism, or even a pneumothorax. Anxiety can result from not getting air or cause a sensation of not getting air. Use lung sounds, oxygen sat, history to differentiate. For instance, clear lung sounds and normal O2 saturation lean toward anxiety hyperventilation. Wheezing or low O2 suggests a pulmonary issue. Neurologic, tingling fingers and lightheadedness occur in panic due to hyperventilation, but similar symptoms occur in strokes or seizures. Postictal, states can have anxiety confusion. Do a quick neurologic exam. Check pupils, grips, facial symmetry, etc. A stroke can cause anxiety, but will usually have focal deficits. Endocrine or metabolic, Thyroid storm or hyperthyroidism can present with anxiety, palpitations, sweating, essentially looking like extreme anxiety. Pheochromocytoma, rare adrenal tumor, causes bursts of adrenaline, panic like episodes with high blood pressure. Hypoglycemia, low blood sugar, can cause agitation, sweating, tachycardia. Always check glucose in an altered or anxious patient if able. Substance use or toxins, stimulants like meth, cocaine, cause panic, paranoia, tachycardia. Overdoses or withdrawals can present as anxiety or panic. Even too much caffeine or certain supplements can trigger panic. On the flip side, some seemingly anxious behaviors could be delirium from infections or intoxication. This is not a complete list, but it shows why panic should be a diagnosis of exclusion. History and patient assessment. If the patient is able to communicate, get a focused history. Ask about onset. What were you doing when this started? A panic attack often has a sudden onset. A medical issue might build up or have precipitating events. Past episodes. Have you ever felt this way before? What was the diagnosis then? If they say, yes, I have anxiety attacks and this feels just like those, that's a strong clue. Many panic disorder patients will recognize their symptoms as familiar. However, be cautious. Patients might think it's panic because it feels similar, when in fact something new is happening. There are cases of real heart attacks initially passed off as just panic by patients who had panic history. Treat each episode on its own merits. Meds and history. Do they have a history of anxiety, depression, or are they on meds like SSRIs or benzodiazepines? That suggests a known anxiety condition. Conversely, a history of angina or diabetes might point to a medical cause now. Triggers or stressors. Ask if something emotionally significant happened. Were you stressed or upset about something before this started? Panic often has triggers like an argument, bad news, a crowded place, though not always. If the person just had a severe argument or is in the midst of a panic inducing situation, that context supports an anxiety cause. Symptoms review. Some features are more typical of panic or anxiety, like fear of dying or going crazy, tingling around the lips, fingers from hyperventilation, or feeling of detachment, unreality. Medical causes like heart attack often lack those subjective fear of dying feelings. The fear in MI is usually about pain specifically. But again, there's overlap. Physical exam, perform a targeted exam based on symptoms. If chest pain, listen to heart, lungs, palpate chest wall. If tenderness reproduces pain, it could be musculoskeletal or anxiety related muscle tension. If neurological complaints, do a stroke scale exam. Many times, an anxious patient has a normal physical exam aside from perhaps trembling and hyperventilation. That normal exam should not immediately make you dismiss them, but it is reassuring. Decision point: medical versus psychiatric. After the above steps, you may start leaning one way. If all findings are normal, vitals, exam, history, and the situation context suggests anxiety, it's reasonable to conclude the primary issue is a neurotic disorder manifesting physically. If any doubt remains, it is safest to treat as medical. In practice, treat for the worst and hope for the best. For example, if a 55-year-old with anxiety history has chest pain after stress, go ahead and initiate cardiac protocol, aspirin, ECG, even if you suspect anxiety, because missing a heart attack would be catastrophic. You can simultaneously calm the patient and explain, we want to be extra sure it's nothing serious. The patient in anxiety will appreciate caution, and if it's not anxiety, you're doing the right thing medically. Bottom line, when in doubt, err on the side of medical. You can later hand off to the hospital that after workup, it appears to be a panic attack. But on scene, do your due diligence. Once you're reasonably confident it's psychiatric, your approach shifts to primarily calming and supportive, while still monitoring vitals periodically to ensure nothing changes. In the next section of this lecture, we will discuss how you, as a provider, should treat these patients in the field. See you then.